Hey guys, thanks so much for coming after our week off. We hope you're all excited for today's webinar, which is on neurosurgery. As always, if you have any questions, please use the Q&A function at the bottom rather than using the chat, as we'll be monitoring that throughout. Also, just to let you know, all of your videos and microphones are already off, so don't worry about that. Today, our lecturer is Ahmad, who secured one of the very competitive neurosurgical run-through training posts this year, straight after his F2. He has taught me personally, and so I have no doubt this is going to be a very informative session. And so without further ado, I'll pass over to Ahmad.
So good evening, everyone. My name's Ahmed, and thank you, Kate, for that introduction. As Kate said, I'm one of the neurosurgery ST1s at the Walton Centre in Liverpool. And I've been asked to give you guys a talk about neurosurgery for sort of final years F1s and F2s. And so this is targeted at sort of neurosurgery for everyone, not necessarily for people who are obviously in neurosurgery or on a neurosurgery job. Neurosurgery might be a very sort of niche specialty, but it will present for anyone in any job. So the first challenge I've had is trying to summarize neurosurgery, and I think that has been very difficult. So the first thing is I'm going to try and focus on emergency cases mostly, because those are the kind of things that you might face as a junior doctor on any other specialty. And then the second problem I faced was, do I summarize spinal emergencies or cranial emergencies? And I've opted to go for cranial emergencies. So, this is going to be a big task, so bear with us. So the first thing to talk about is if you are approaching a neurosurgical patient or a patient you think might be a neurosurgical candidate, how do you approach them? So neurosurgical patients are often quite unwell, and they can deteriorate very rapidly. And therefore, your assessment should always start with ABCDE. I say this a lot when I'm teaching students, and I myself have used it, and it's saved patients before. So always start with ABCDE. And essentially, the principle behind it is that there's no point saving a brain from pressure or a bleed or anything else like that if there's no blood pressure to supply blood and oxygenated blood to the brain. And then if you are examining a neurosurgical patient, an acute neurosurgical patient, these are the three principal things you need to examine. And if you're ever making a referral to neurosurgery, which I assure you many of you will, and it's one of our bugbears when people are referring to neurosurgery and they don't know what they're talking about, or they haven't looked for the key important bits. So the key things for us in neurosurgery are the GCS, and the breakdown is absolutely critical. A GCS of 14 can be a loss of 1 point on any of these three categories. And if you can imagine, if you just picture, if you're describing a patient who's got lost 1 point on eye opening versus verbal response versus motor response, they're three very different vignettes. They're three very different patients. And so it really is important to describe for us the exact breakdown. So whenever we're reporting GCS, we will say E4, V5, M6. We'll state the breakdown. Secondly, examine the pupils. Always check that the pupils are equal, reactive, and if there's any asymmetry or sluggishness, then comment on that. And then last but not least is focal deficits, which is a very general term for, is there any motor weakness in any of the limbs? And that can be, like, very gross weakness can occur when it's an intracranial pathology. Very focused weakness occurs with spinal pathology. So I haven't really gone into that today. But in intracranial pathology, the general patterns you get is weakness in one or more limbs. And so just general weakness is really important to document. So a quick point on why the pupil dilates. So it's a very just quick point. The pupil dilates because you have the uncus of the brain, which is the most medial part of the temporal lobes. They get pushed down in transtentorial herniation when you have high pressure intracranially and the brain is being pushed downwards across the tentorium, which is the fold of dura between the cerebellum and the rest of the brain. When the pressure is pushing down and the temporal lobes are being pushed down and medially, then the most medial part of the temporal lobe presses straight on the oculomotor nerve. And so that's when you get pupillary dilation. And you can see it here in this scan, in that just where that outlined arrow is, you can see that that's uncal herniation pressing down right next to the midbrain. So another key principle that's important is understanding when a neurosurgical operation would even be considered. And this is important because we get a lot of referrals in neurosurgery for patients which, if anyone had any basic understanding of neurosurgery, would realize this patient really isn't worth referring at all. So the first principle is if there isn't even something to remove or any pressure to decompress. It's not uncommon that we get in neurosurgery people referring to us people with symptoms that, as it turns out, the patient has absolutely nothing on their scans that is a mass lesion causing compression or pressure. And therefore, it begs the question, what would neurosurgery do? So when you are thinking about a neurosurgical patient, when you are assessing a neurosurgical patient or referring one, you have to think, is there something for neurosurgery to remove? Because ultimately, it's a surgical specialty. And surgery is all about cutting and removing or fixing structurally. The other key thing is, so if there's a mass, but then is there associated severe and progressive neurology that's associated from that mass? And that's in one of those three domains that I mentioned earlier. When you're examining for a patient, those are the three key things you're looking for that tell you about if there's generalized neurological dysfunction. And that's if the patient's GCS is poor or if it's changing and dropping, if there's focal deficits, again, if they are worsening, and if there's pupillary dilatation. Usually if there's unilateral or bilateral, but either or, if the pupils are dilated and fixed, then that hints at severe pressure intracranially that can potentially be decompressed surgically. And last but not least, and this is a principle for all surgical specialties, is if the patient is a good candidate for surgery. If the patient is medically fit enough to deal with the insult of surgery, because surgery is ultimately an insult. It's ultimately a very severe attack on the body that requires a healthy person to be able to recover from. So often we get referrals for patients who are, in their 80s with several comorbidities, and often the response from neurosurgery is that this patient, by the time they even get to the neurosurgical center, they would have deteriorated so badly that surgery is just not going to change the course of their disease. So these are three key principles that run through any thought about a neurosurgical patient. So the next thing that I thought was we should probably discuss CT heads a bit, and we should get you somewhat fluent with CT heads. And the reason being is, and this is no exaggeration, CT heads for us are like chest x-rays. We order them at the slightest whims. If a patient has a slight drop in GCS, if a patient has a headache after something, we will order a CT head. And yes, it's a lot of radiation, but it's easily our best way and our quickest way of getting a very good picture of what's going on inside someone's head without having to do anything invasively. So CT heads are density based. It's the same principle as an X-ray. X-ray beams being fired through something and then obviously being absorbed by very dense materials. And this Hounsfield scale is basically a scale that it was designed to standardize the densities of materials, with water being 0. So I say that because when you're reporting on a CT or describing a CT over the phone, then your terminology should be density based. That makes things, I think, a lot easier to remember and understand. Is something hyperdense or hypodense? And that's just to get the point across clearer, that's different to MRIs, where because the MRI is detecting a sort of signal, then you can say in an MRI it's hyper intense or hypo intense. So in CTs it's hypo or hyper dense. And then the next principle to understand is when we request CTs with contrast, and these are principles that go across for any surgical specialty, any specialty really, when you're requesting a CT. When do you give contrast? When do you give IV contrast? You give it in these three scenarios. When you want to see the vessels themselves very clearly, the arteries or the veins, and in that case, you have to specify to the radiologist whether you want to see the arteries or the veins. and then they can scan at the right phase, the right timing, when they think the contrast will be going through the arterial or venous system. And then lastly, the last two are actually related, because if you want to see inflammation or malignancy, and because both of these processes cause sort of increased permeability in the blood vessels of the brain, so then you give the contrast, and essentially the contrast leaks out of the vessels and into the surrounding tissues. So then you get contrast enhancement. And so those are the key areas. So obviously inflammation, and by inflammation I do mean non-infective processes, but also infective inflammation. And you can see in this scan, so this is, so just in case anyone's forgotten, you know, this a CT scan, the orientation is that the patient's feet are towards you. So then for later on when we're understanding right and left, and you can see on the left, it's a CT brain and without contrast, and on the right is a CT brain with contrast. And you can see that within the brain sulci, there are certain these new white spots. These are all the arteries within the sulci. And you can also see that within the ventricle, in the middle there, there's sort of these newer white patches, and that's the choroid plexus, which is very vascular. So this is the normal CT, and you can see that it's just showing up normal structures, the arteries and the choroid plexus, when you give contrast, that is. So a few other quick anatomical points to understand the CT and to understand brain pathology is on the left, you've got the key dural folds inside the head. So the key two are the falx cerebri and then the tentorium. And the reason they're important is because together they divide the skull into essentially three compartments. The falx cerebri divides the top compartment into a left and right part. And then the tentorium divides the skull into an upper and a lower part, a supratentorial and an infratentorial part. And on the right, we can see all you need to take from this diagram is that around the midbrain and the cerebellum, there are, I don't know, can you see my mouse actually, Kate?
Yes, we can. Yes, we can.
Okay, cool. Because then it makes it easy to explain. You can see essentially this here is the tentorium cerebelli. So above here is all the supratentorial parts, and here is the infratentorial compartment, which is quite small. And that's important. We're going to get to it later why we get worried about infratentorial pathology, because essentially there's not much space here for any kind of expansion. And right here you have the brainstem with all your cardiorespiratory centers. But importantly from this slide, the key things I want you to take from it is that there is a space here and spaces here. These are all called cisterns, where they're essentially enlargements of the subarachnoid space. And they're important for looking later at a CT and assessing how urgently or how unwell the patient is. So looking quickly at some normal anatomy of a CT scan, and this is important because you will be looking at CT scans a lot, and sometimes before the radiologist has had an opportunity to report it, especially if you're working in a small district general hospital. So these are all CT heads without contrast. From the right is a top slice, and then we're coming to the left. This is a slightly lower slice, and this is a middle slice. So the first normal structure is the skull, very nicely thick and dense, lots of calcium, very dense. Then in the middle is the falx cerebri, which we said is a dural fold, and it divides the supratentorial compartment into left and right. And you can see that it's quite dense. This is important for looking at midline shift and assessing if there's any herniation across this falx cerebri. Then the white gray boundary is important for assessing essentially if this is lost, if the white gray boundary is lost on one side or the other, it's a prognosticator. It highlights that there's been major cerebral edema or ischemia on one side of the brain. And critically as well here, you can see that there are some sulci visible. You can see these black areas here. These are sulci. So this is CSF in the sulci. And what that highlights is that this brain is not under a lot of pressure. So we can get a very good assessment just by looking at a CT scan of whether this brain is under a lot of pressure or not. Next is the lateral ventricles. Now the lateral ventricles are really important markers. They highlight for you, we use them as landmarks for position of other structures. And also critically, they are often the first to dilate when you have hydrocephalus. So you can see here that in this middle slice, you can see that this is the sort of anterior horn of the lateral ventricle. This is sort of the beginning of where the inferior and the occipital horns meet. And then here, this is the occipital horn here. Now, importantly, and we'll see it in some other scans later, the temporal horn, which it can sometimes be called the inferior horn, the temporal horn is usually not that visible. It's usually, in a normal person, it's usually quite collapsed and quite small. And so usually we use that as a marker. If that's slightly dilated or slightly round, then that highlights that there's probably hydrocephalus or impending hydrocephalus. The third ventricle is in the middle, and the thalamus is sitting next to it. I know some people probably don't like neuroanatomy, and some people have probably forgotten neuroanatomy. So this is why this is hopefully a useful quick refresher. And then lastly, just in front of the thalamus, sitting next to the anterior horn of the lateral ventricles, is the basal ganglia. So this is all just normal anatomy. And then on the right is a very high slice in a normal CT, and on the left is a very low slice in a normal CT. So the right slice, there's not much for now to look at. On the left, you can see a lot of the lobes are labeled. The temporal lobes, so an important point to realize is that far down on the brain, where the brain sits on the skull, the parts that actually sit on the skull are the frontal lobes, the temporal lobes, and the cerebellum, not the occipital lobes. And you can see here critically that there's a lot of, so we'll just talk about some of these spaces, these key spaces to look at. So firstly is the Sylvian fissure. You can see it here. This is the area between the frontal lobe and the temporal lobe. And then you can see the basal cistern. So these are the CSF spaces I spoke about earlier, which sit around the brainstem. And they're really important for prognostication, for assessing how high is the pressure intracranially. And then that white edge is the tentorium cerebelli. Now the tentorium cerebelli is a sheet of dura, and it's actually sort of horizontal or parallel to the screen right now. So this is a kind of a 2D image. It's kind of a cut through the tentorium. So a really useful thing to do to understand CT anatomy much better is to actually get an actual one in a hospital and sort of slide through the slices. Because as you move through the slices, you get a 3D feel for the structures. So the tentorium here, while it is just a slice here, just a line, it is actually a whole sheet covering the entire cerebellum. And lastly, these black, very, very black spaces are mastoid air cells. And the reason they're useful is twofold. Firstly, if you have a skull-base fracture, it can happen that the mastoid air cells get full of blood. And so you get a sign called a pacification of the mastoid air cells, which can be a very easily missed sign for the fact that there's been a skull-base fracture. And secondly, you use it as a reference point for what the color of air is. And you can see that it's much blacker than the subarachnoid cisterns, these areas. If you look at it's very subtle, but it is much blacker than here. And the reason this is important is because sometimes in a head injury, you can get air inside the brain or inside the skull. And so you'll spot it as various points within the brain or within the subarachnoid cisterns that's actually even blacker and the same color as the mastoid air cells. So I've been asked to prepare some SBAs for you as well. I think SBAs are probably a good way of checking that you're awake. So we'll start with this one. So which cortical area is labeled X? Thank you, guys. That's what I have to fill as well, don't I? So people filling it in. So what are the results? Okay, very good. So most people, so 43% said primary motor cortex, and that is correct. The next group, 33%, so still a sizable number, said primary sensory cortex. So I can see why, but essentially the key features of this is the high slice CT, And the reason this is useful is usually to be able to anchor and find where your motor strip is. So you can see here, this bit here is your central sulcus. Okay, so the central sulcus is the most reproducible coronal sulcus. And anterior to it is going to be the primary motor cortex, and posterior to it is going to be the primary sensory cortex. Okay, so this is the primary motor cortex. Now, the reason that's really important, finding the primary motor cortex, is that for some of the, relatively simpler procedures, there are no simple procedures in neurosurgery, but for the relatively more simple ones that we sometimes do in an emergency, say for example an EVD, an external ventricular drain, when a patient has hydrocephalus, they have acutely rising pressure, and we need to relieve the pressure by inserting a tube into the ventricles, then you have to go through the brain matter, but you want to avoid the motor cortex. There are certain parts of the cortex that we call eloquent, and by which we mean if they are injured, they cause a much more significant deficit that causes severe disability to the patient. And so the motor cortex is prime among them. So usually we try to avoid that and go anterior to it. So this is why it's really important to be able, just using these landmarks, identify some of these gyri. Fine. So we'll do some cases just to keep you all refreshed. Some people learn better with cases. So a 78-year-old man who has a 2-week history of progressive confusion and unsteadiness. Nothing really in his past medical history or drug history. And now examination, he's got E4, V4, M6. So give you a second, try to work out what's wrong there. So he's just so V4 is essentially the deficit. He's confused. He's talking fully, but he's confused. And his PEARL means pupils are equal and reactive to light. And he's got left-sided weakness affecting his arm and leg. So you can see that when we're looking for acute head injuries, we're talking in very global terms about the kind of weakness that we're looking for. So I'll give you 20 seconds just to write for yourself or think quickly about as many features as you can from this CT, as many problematic features. Okay, so these are all the features I could find. And let's see how many you guys thought you got. So when you're describing a CT problem, so you first describe the actual main lesion that you see. Of course, if you're in an OSCE or being examined by someone, don't forget the usual stuff that gets you a lot of marks, like just saying what the scan is. This is an axial CT head, making sure you identify the right patient and the date and time. Just those basics are key. But for this talk, we're just going to focus on the pathologies. So the main pathology, it's an extra axial, meaning it's not part of the brain, it's outside of the axis, which is the brain and spine. So it's extra axial, crescent-shaped lesion. It's got mixed density, and there's layering there, so that you can see that from the top, which is the most darkest color, or the most hypodense, to the bottom where it's the most hyperdense. It's really graded. It's overlying the right frontoparietal region. It's causing midline shift, compression of the ipsilateral ventricles. Sorry, I should have corrected that. And it's also causing sulcal effacement on the right side. So you can see that on this side, there are still some sulci that you can see, right? But on this side, there are absolutely no sulci. So what's the diagnosis? Nice. Okay, so 53% said acute on chronic, and then we got a reasonable mix saying chronic or acute or extradural hematoma. So it's an acute on chronic subdural. So what points to the fact that it's a subdural? Well, firstly, its shape. So it's crescenteric, meaning it's not being held back by any cranial sutures. So essentially, it's spreading equally across the entire brain, and therefore it's not being held by dura. So it's subdural. And also going in favor of this is the history. It's a 2-week history of progressive confusion and unsteadiness. So subdurals have this kind of slow history to them. So how do we know if it's acute or chronic? Well, firstly, the history points to the fact that there's a chronic component to it, the fact that it's 2 weeks. What points to the fact that it's acute or chronic? The layering in the CT scan highlights this. What happens with the subdural is you get a head injury, maybe 2-3 weeks ago, the patient barely notices it. And then you get a small tear in a dural bridging vein. And that bleeds sometimes a little bit, sometimes a bit more. But essentially that blood, the inflammatory process that occurs in response to that blood creates a cavity full of fluid, and that fluid expands. And that's essentially what this bit is. You can see that this top part is hypodense. It's almost the same color as the CSF in the ventricles. So this part is quite hypodense, it's quite watery. And when you actually do open up to try and relieve the pressure here, you find this bit's really watery. It just looks like a really old blood. It's just quite liquidy and brown. But down here, this bit's quite hyperdense. This bit's quite dense, and that's acute blood. Acute blood, when it first bleeds, clots and becomes quite dense. And so that's what you're seeing here. And why is it layered like this? Because the patient is lying on the back of their head. They're lying on their back. So the top of their head is here, and their nose is here, and the bottom here, and so the heavier parts all fall downwards. So the big clots are falling down here, and the lighter, less dense liquid is coming up here. So this diagram is just to highlight what we mean by dural bridging veins. So on this side of this brain, you can see this is the dura, really tough sheet of protective material. And then these are what the dural bridging veins look like. They're these small veins that bridge from the brain itself to the sagittal sinus, and sometimes not to the sagittal sinus, but essentially they go to the dura. So you can see that with the elderly especially, when they have some cerebral atrophy and their brains shrink a bit, with the slightest knock, these can tear, and then you get bleeding underneath the dura. So management of these patients, again, you start with ABCDE. I'll always state this, but this guy is not that unwell, is he, at the moment, because he's got a 2-week history. Analgesia is important because they do have some very horrible headaches. There's sort of an not necessarily well-backed argument for use of low-dose dexamethasone. Variable people use dexamethasone with these patients to help reduce the swelling around the hematoma itself. But the mainstay treatment is surgery. And the surgery is usually in the form of just burr holes. So essentially you put 2 holes overlying the actual hematoma, and then you just wash through one hole into the outside other hole. And just because it's often quite liquefied, and if there are any clots, it's usually quite small, it can easily come out. If it's a very old hematoma, then the concern is that you might get loculations. You get little septi within the actual hematoma that then makes it a bit more difficult. And in that case, you might need to take off more bone to be able to access the hematoma and clear it. So in this chap, so we said this is just to remind you of the history. How urgent is the surgery on this patient? Okay, so can they see the results, by the way, or not?
Yes, they should be able to.
Okay, cool. So we have quite a division here, but importantly, most people seem to have recognized that this is not life-threatening. Okay, it can become life-threatening if it's sort of in its early phases of swelling and it keeps on swelling and essentially causing uncal herniation and possibly brainstem compression, but that's very, very rare. This is not a life-threatening condition, but it is serious and needs to be relieved as soon as possible. but not within minutes, and not necessarily even within hours. The right answer is that you usually aim to get it done same day. Okay, and in this chap, you probably will aim to get it done same day or within hours, mostly because of the fact that he has unsteadiness and left-sided weakness. So these are actual deficits that need to be reversed as soon as you can, but not necessarily within minutes. So yeah, how would I remove this? Fine. So another very common dilemma you're all going to face, and this is affects patients outside of neurosurgery, geriatrics. If you're doing general medicine, if you're doing A&E, if you're doing any other specialty with patients who are slightly over the age of 50, you will come across patients who have an intracranial bleed of some sort, but very commonly subdural haematomas, and they are on either anticoagulation or antiplatelets, and they cause a real dilemma for neurosurgeons because the brain is very prone to bleeding, and any slight bleeding can cause a rise in pressure intracranially. And so it's a real dilemma. And obviously you can't operate on someone who is anticoagulated or is on antiplatelets, because the moment you cut into the skin or drill into the skull, the bleeding just doesn't stop. So it's a real dilemma what to do. But essentially the first step when you have a confirmed bleed intracranially is going to be reverse whatever agent they're on. And I've spoken so generally, I haven't went into the specifics, partly because this is a neurosurgery talk and not a hematology talk, but partly because there are so many agents and there are so many different policies for what you reverse with, and what you do, that essentially it's gonna involve whatever hospital you're working in. It's going to involve discussing with your seniors and discussing with your hematology department. But common issues that you should be aware of is that, for example, with warfarin, it's vitamin K or prothrombin complex. With aspirin or clopidogrel, the antiplatelets, what we usually do is if the surgery is really important within, a day or two, then within hours, we usually give fresh platelets that haven't been affected by aspirin. And if it's any of the sort of fancier DOACs, the direct oral anticoagulants, then it depends on whether a reversal agent is even available within your hospital or not. And there you're going to definitely have to discuss with hematology. So you reverse whatever agent they're on as soon as you can. You then operate as soon as you can, because you want to minimize the amount of time that they are not anticoagulated if they urgently need it. And then step 3, another very general statement, but again, because there is so much that goes into this and so much discussion and so a lot of senior decision making is needed here, is you need to restart the agent as late as possible from the point of view of neurosurgery, but as soon as needed from the point of view of all the other specialties. And this can be a really tricky part of dealing with intracranial bleeds. And for example, there are slightly some more straightforward patients. So say, for example, you have a patient who is on antiplatelets, and they've been on aspirin for 10 years because of a small cardiac episode they had 10 years ago. They've been stable since then. They've not had any other episodes, and they're just taking the antiplatelets because of prevention. And that kind of patient, you're probably okay to stop the antiplatelets for a good few weeks, maybe, just to allow the bleeding to properly stop and the effect of your surgery to get proper hemostasis following surgery. But let's say it's someone with a mitral valve, a metallic mitral valve, and they have very high risk of getting clots forming. Or if you have a patient who has a significant past medical history, there are lots of patients out there who you look at their past medical history and they've had 4 DVTs and 2 PEs and a mesenteric artery thrombosis. Those are real crisis patients, because the moment you stop their warfarin or whatever DOAC they're on and you reverse it, they are very, very high risk of developing a clot and developing another PE or another stroke because of it. So essentially the key principles are there, but you're going to be needing to discuss with hematology and with neurosurgery to work out essentially a risk-benefit analysis and deciding when to restart the medication. So another case, you have an 18-year-old chap, young guy, who has come 30 minutes after being hit on the head. There was no loss of consciousness, but he's vomited several times and he has a severe headache over the left-hand side. And on examination, his GCS is completely normal. his pupils are equal and reactive, and he has no neurological deficit. So this is an algorithm which is potentially worth familiarizing yourself with. Now, I'm not going to go through it now. It's a very complicated slide. We will just go, this is the summary here. But essentially what this algorithm is, this is the nice guidelines for when to request a CT head following head injury and how urgently it's needed, i.e. there are three categories of patients following a head injury from NICE's point of view. Either those who need it within an hour, need a CT scan within an hour, or those who need it within 8 hours, or those who just don't really need it necessarily. And you might think that this guideline is relevant only for people who will do an A&E job, or if you're only interested in A&E, but actually a very common problem is junior doctors that you'll be called to see when you're on call in the middle of the night is the elderly patient who was walking to the toilet and fell over. And someone might have seen them hit their head, and they might not have hit their head, and you're not quite sure if they have hit their head or not. And so this tool is important for that kind of scenario where you're deciding, do we need to do a CT head for this patient? So the key principles for needing a CT head urgently, i.e. within an hour, is these simplified versions of the NICE guidelines. So interestingly, if you look at the first line, if their GCS is less than 13 at initial assessment, then they should get a CT scan. But if their GCS at assessment was 13 or 14 when they first got hit, that's actually acceptable. Your patients are allowed to be a little bit phased or confused or struggling to open their eyes immediately after the injury. But we expect most people to have recovered within 2 hours. If someone hasn't recovered their GCS back to 15 within 2 hours, then you order a CT scan. Goes without saying, if someone has focal neurological deficit, if they have any weakness, then you're going to order a CT scan to work out what's wrong. If they have developed a seizure, now bleeds or other intracranial injuries can cause seizures. If you think that there's a fracture, then of course CT is one of the best modalities to look at the features of that fracture. And if they've vomited more than once in an adult, this is another interesting one in that you're allowed to vomit once after a head injury. Okay, whether it's, but if you vomit more than that, then it's an indication for a CT. And amnesia more than 30 minutes. So again, it's normal to have a little bit of memory loss. So if you have 10 minutes of memory loss, that seemed to be acceptable, as it were. But if you can confirm that it's more than 30 minutes, then that's a significant amount of memory loss. And then if there's been any loss of consciousness or any amnesia at any point with any of these other risk factors, then you'll get a CT head. And you can see that dangerous mechanism of injury, kind of a more general statement that allows you as a clinician to make a judgment, because NICE guidelines are just that. They are guidelines, and ultimately you have to make a clinical decision a lot of the time on your own. So our 18-year-old chap with normal GCS and no focal deficits, he's just vomited several times. This was his CT scan. I'll give you 15 seconds to kind of think about the main problems. Okay, so I'm sure everyone's picked up on the main lesion, but what I'm hoping people are picking up on as well is the other features that indicate the state of the brain. Okay, so the main lesions are very sort of straightforward for most people to pick up on, especially when it's a glaringly obvious one like this one. But what I'm hoping people are trying to pick up on as well is signs of how the brain is doing, how the brain is being affected by this lesion. So again, this is an extraaxial lesion. It's lentiform in shape. It's hyperdense. You can see it's almost the same color as bone. It's overlying the right frontal lobe, and critically, it's causing midline shift. It's causing lateral ventricle compression on the right side. You can see the asymmetry of the posterior horns of the lateral ventricle, and it's causing sulcal effacement again on the right side. So this is what I mean. The lesion is there. It's one thing describing the lesion, but the other thing that highlights the urgency, or it comes into our minds in assessing how urgently surgery might be needed, is what does the brain underneath look like? Is the brain being aggressively affected by this lesion? So what's the diagnosis? Good. Yeah, so most people got it right. It's an extradural hematoma, okay? And the reason this is an extradural hematoma, well, very acute injury. It's very hyperdense. So the fact that it's hyperdense indicates that it's very acute blood, and it's lentiform in shape. So what happens is that the blood is happening between the bone and the dura, and dura is usually really nicely adherent to the inside of the skull. It's usually really nicely stuck. So when there's a high pressure bleeding, it tears off the dura. But there are certain points where the dura is fused to the skull, and those are the sutures, the cranial sutures. Those are the points where, you know, the blood pressure isn't good enough or high enough to tear the dura off those sutures. So this is why. So basically, you get this shape because the bleeding is being limited by the sutures. So here it's the coronal suture, and here it's actually the falx usually that's limiting it medially. So another SBA. So usually which vessel is injured to cause this particular pattern and this particular bleed? Good. Everyone's read this somewhere. So the middle meningeal artery, okay? So the middle meningeal artery comes from the foramen spinosum down here, curves underneath between the skull, between the bone and the dura, and basically on head, if you get a head injury on the lateral aspect of the head, fractures here can easily tear a branch of the middle meningeal artery. Now, this question highlights another key important principle. Chronic subdurals or subdural bleeds generally are usually venous in nature. So they are a bit more low pressure, and they're a bit more slow in their development. So you have a bit more time with the venous bleeding in a subdural. Extradurals are usually arterial. And one way to think about this is that, as I said, the dura is really strongly stuck to the inside of the skull. So it needs something with a lot of pressure to tear the dura off the inside of the skull. And that's going to only be really arterial blood. Yeah. And just to, because I think a lot of people, sorry if this is unpleasant to some people, but a lot of people, you know, learn about neurosurgery and intracranial problems, and they never actually properly see what it looks like. So this is just a quick picture to highlight. This is what an extradural looks like. So you can see the surgeons have just taken off the bone. They haven't actually breached any dura. So you can see the dura is actually sitting there. That's the dura, and this here is just a congealed mass of clot. Okay, and it's not that large a volume, but especially in a young patient, where their brain is really healthy and really filling up the cranial cavity, and they have very little room to spare, the slightest bleeding can cause a significant deficit or significantly high pressures inside the skull. And then also importantly is the speed of increase of that volume. In a chronic subdural, you get slow increase in the volume. So there's sort of time for the brain to compensate, time for CSF to leave the cranial cavity, and for the pressures to maybe not rise that aggressively. But in an acute extradural, like this one, the bleeding is arterial, it's quick, and so there's not much time for the pressures to sort of equilibrate. Now, anybody, just to give you a second, if you can try and work out where the problem is here. So the problem is right there. So again, it's hyperdense. It's an extraaxial lesion. So it's the color of acute blood, and it's lentiform in shape. And so it's in the infratentorial compartment. And if you remember, I said that the infratentorial compartment is where you have the brainstem and the cerebellum, and it's a much smaller compartment with less space to spare. So for this sort of patient, we'd be much more worried, and we'd be keeping an eye, a much more careful eye on them, because they can very quickly deteriorate from a cardiorespiratory point of view because of brainstem compression. And also importantly, in this scan, a few other quick features to highlight. You can see these black little dots inside the bleed. Those black dots are not CSF. They're the same color as air. They're very, very dark. That's pneumocephalus. That is air inside of the bleed. So immediately that should highlight to you that there's also a skull fracture somewhere. And if you look on the mastoid air cells here, you can see that they're quite opacified. So there's bleeding inside the mastoid air cell here, and the skull has been fractured. So air has breached, probably from the mastoid air cell actually, and made their way into the actual clot itself. So this is just another variant of an extradural, a very important variant, because we all see the one that's the middle meningeal artery somewhere on the side of the head. But another variant that's really important to bear in mind is when it's in the posterior fossa like this. So essentially, we've gone over the two commonest types of head injury consequences, but there's a lot of different consequences from a head injury. And head injuries are going to be very common problems that you see. Bleeding variants are important. The brain you're going to get bleeding into lots of different compartments within the skull, and all of them have their own different consequences, their own different speeds and prognoses, and all have their own different surgical management. But you can, and it takes some practice to get used to seeing or identifying these. But you can get, so subdurals and extradurals we've been through. You can get subarachnoid hemorrhages, which are a bit more subtle. The blood essentially follows the sulcal patterns. And you can get intraparenchymal hemorrhage, so you get actual hyperdensities within the brain matter itself, and you can get intraventricular DIAI, defectional injury, is a type of injury that you detect on MRI, and you only really detect later. And usually the patients may be medically okay otherwise, but they have severe cognitive deficits. And what essentially happens is that the gray and white matter move at slightly different speeds when the head is knocked. And so essentially there's massive shearing and tearing of the axons. And this is the type of injury has one of the worst prognoses in all of neurosurgery, because you can imagine there's not much you can do to replace torn axons. And then last type of head injury consequence is all the different types of fractures that we can get. You can get skull-based fractures. You can get skull convexity fractures, which might be slightly easier to manage. And don't forget the associated other injuries that are really important not to miss when you are assessing a head injury patient. And that's patients with the facial fractures, and have a very high suspicion for C-spine injuries. I can't remember the exact figures, but there are figures out there published for a percentage of people with severe head injuries and associated C-spine injuries, and they're often missed. So unless a patient is sort of coming in as a suspected trauma, and they activate the trauma sequence, and then people do a sort of assessment of the C-spine after, immobilizing the C-spine, most people usually miss the C-spine injury. So have a very high suspicion for that. So here's just some other quick head injuries just to highlight. This is a CT head here on the left that you can see doesn't really show that much, but you can immediately see that the skull appears to be breached at certain points. So then you can set the bone window. And this is something that you just have to, in your local hospitals, ask a radiologist, or maybe ask someone senior to show you how to set the bone window and look at bones more clearly. You can see multiple skull fractures there. This is a patient who's likely going to have other intracranial injuries, and possibly a C-spine injury as well. And then here, last but not least, in the head injury section, is someone with contusions, bifrontal contusions. And there you see it's just hyperdense areas within the actual brain matter itself. And the commonest areas for frontal contusions are the frontal lobes and the temporal lobes. And the reason being is that when the head is knocked and the brain sort of moves aggressively inside the cranial cavity, then the frontal lobe and the temporal lobes are sitting on bone, and the bone they're sitting on is actually quite rough. And so that trauma of aggressively moving over that bone is thought to be what causes contusions in these areas. So you very rarely get contusions this big, especially in the occipital lobe, because of the fact that it's sitting on a smooth surface of the tentorium. So as I'm a Walton trainee, I have to sort of plug some Liverpool research, and this is hot off the press. This is published this year, a couple of months ago, but essentially because in a very common problem, like I said, in neurosurgery, is getting referrals from people who really, getting referrals, or people haven't really thought through whether neurosurgery are going to even do anything. And usually it's because people are sort of under the pressure of saying, okay, there's something on the CT scan, we need neurosurgery to clear it, we need neurosurgery to say nothing to be done. So the Liverpool head injury tomography score is being designed, and it's just been published and is being used in our area, so being used in the district general hospitals that refer patients to us. And essentially it's a score to try to highlight that sometimes you can have things on the CT scan that are really very minor and don't require any neurosurgical input and just require local medical management. So if you just look at some of the lower scores, is, for example, a score of 1, if a patient has tentorial endoparafalcine subdural hematoma, so a small subdural hematoma that's not causing any medical changes, then this patient scores 1. So the abnormal scan, but it says here, admit locally for neurological observations and follow NICE head injury guidelines. Other things like score 1 is after head injury, if you just get some small subarachnoid hemorrhage, so a small amount of subarachnoid hemorrhage, and it's just peripheral rather than central, so deep inside the basal cisterns. Again, that's something that it can be minor, and just a patient can just be admitted for neurological observations. Single contusion, so a patient can have a contusion less than 1 centimeter, so blood, a lump of blood inside the brain parenchyma itself, and that again only scores a 1, because these are injuries that usually resolve on their own and just need medical management rather than any active neurosurgical input. And then fractures, again, a small fracture that's undisplaced, again, there's not much that needs to be done, and therefore you score it a 1. So this has just been published, and obviously, I recommend going through it because it's actually quite educational to look at what matters on a CT scan. You can see, for example, that in the skull fractures, there's no category, there's no category that scores a 2, because anything more than an undisplaced fracture scores a 3, meaning that's a surgically significant injury, so refer to neurosurgery for advice. Okay, whereas in all the other categories, actually not on the extraaxial hematomas, again, there's only categories 1, and then we immediately jump to a category 3. So this scoring system is actually quite educational. So managing medically a neurosurgical patient, this equation is key to a lot of what we do. So CPP is cerebral perfusion pressure, and essentially it's how much overall push is there of blood to get inside the brain, to get to the brain. And obviously it goes without saying that brain needs to carry oxygen and needs to carry nutrients, i.e. glucose. So when you're managing a brain injury patient, it's important to make sure that A, they have a good oxygenation and therefore good airway, and that their glucose is normal, okay? So the cerebral perfusion pressure is calculated by the mean arterial pressure minus the ICP. So the mean arterial pressure is essentially how much push there is of blood into the cranial cavity. That's somewhat obvious. And the ways that you can support that or augment that or increase the mean arterial pressure is by giving the patient fluids or inotropes, which you won't be doing as junior doctors. Probably it will be someone senior in ITU. And of course, stopping any other bleeding so that you can maintain volume. And then, of course, ICP, intracranial pressure, is the amount of resistance to that blood flow. So, I mean, this equation is fairly straightforward, the amount of push minus the amount of resistance is the amount of total sort of pressure that can get blood effectively to the brain. And managing high ICP. So there are medical options to manage high ICP, to basically bring it down. And a lot of them, so mannitol and hypertonic saline work by essentially osmotically is the main theory, and sort of withdrawing some of the extra fluid in the brain parenchyma itself. Hyperventilation, so that you bring down the patient's CO2 and cause some vasoconstriction, which reduces the blood volume inside of the skull. And then that helps reduce ICP. And then sedation. And sedation works essentially because by sedating the brain, you reduce its oxygen and glucose requirements. And so you reduce the blood flow to the brain, because the brain, the more the brain functions, the more vasodilation that occurs inside the brain, and therefore the more blood volume again. And one point I forgot here medically, and this is a very simple thing that you should all do when you go to a patient who you suspect with a head injury or high ICP, is lifting the head up, lifting the bed up, just because that increases venous return and again reduces the blood volume intracranially. And if all of these things are done, if medical options have all been tried and nothing works and the ICP is still quite high, then that's when the patient is a candidate for surgery and decompression of some variant. And it will depend on what exactly is causing the high pressure intracranially as to how much bone you remove to access. And sometimes we remove a lot of bone. So one of our biggest operations is a decompressive craniectomy, where you can remove essentially half of the skull to try and relieve the pressure. Fine. I'm noticing that I'm also running out of time, so I don't want to. I'm also running out of battery. I don't want to. It's okay. I mean, I don't want to. I've got like maybe a few more slides, maybe 4 or 5. Do you want me to stop for questions or?
No, I think you can carry on, and then we'll just have a couple of questions afterwards, if that's okay.
Okay, cool. So I'm just gonna some final quick cases, because so far I've covered head injury, and I think it's head injury and its consequences and its sequelae are some of the commonest problems you're going to face. But let's just go quickly over a few other common problems you're going to face. So just quickly, what is this scan showing? Give you a second to think about it. So to describe the CT scan, so the main problems are that there is acute blood in the basal cisterns. You can see it here. All of this is acute blood in the basal cistern sitting in front of the brainstem. This is the brainstem. This is the temporal lobe. This is the frontal lobe, and it's sitting all basally. There's a hematoma in the right anterior front temporal lobe, and it's got surrounding edema. This hypodense area is essentially increased fluid within the brain parenchyma itself. There's also acute subdural blood. I don't know if you can see all of this here. There's acute subdural blood. So it's subdural because it's crescentic in shape, and it's acute because it's very hyperdense. And there's hydrocephalus. So you can see here, this is what I was referring to earlier about the temporal horns of the lateral ventricles. They usually collapse in a healthy person, but here they're quite dilated. So that alone, just that one little sign highlights that there's hydrocephalus developing. And of course, there's midline shift. It's really subtle, but if you sort of follow down from here, you can see slightly that the brain is being pushed to the left side. Okay, that's probably partly because of this hematoma and partly because of this subdural. So what's the main diagnosis here? Okay, so this one is confused a few more people, but a lot of people still got it right. So well done. So it is a subarachnoid hemorrhage. Now this is a slightly more difficult one because there's lots of features, but the unifying problem that connects all of them and is causing all of the others is subarachnoid hemorrhage. So you've got the evidence is that you've got this hyperdense blood all in the basal cisterns and it's in all directions. So it's following the sulci. Okay, so these you can see here it's in the interhemispheric fissure between the frontal lobes. It's in the sylvian fissure. Okay, and then it's also caused a hematoma. So what that tells you is that there's probably whatever lesion, most likely an aneurysm, that's caused this blood is probably really close to the brain matter itself. And so it's caused a hematoma as well as lots of blood in the subarachnoid space. And the bleeding is actually continuous with the subdural space here, okay? And the bleeding itself, the blood itself can cause impairment of CSF flow. So then you end up with this hydrocephalus, okay? So the unifying diagnosis is subarachnoid hemorrhage. So subarachnoid hemorrhage management. Now, subarachnoid hemorrhage is you know, it's in the name that the key problem that we're looking at is the blood in the subarachnoid space. For some reason, blood in the subarachnoid space causes a very unique set of problems that develops. And actually, it's not just aneurysms that can cause subarachnoid bleeding. You can get subarachnoid bleeding from trauma, as we said earlier, from head injury. You can get it from any vascular malformation. So the next most common problem is an AVM, an arteriovenous malformation, where you get a clump of abnormal vessels, basically, an abnormal clump of vessels between arteries and veins that are fragile and therefore easily bleed. But with any subarachnoid bleed, until you have to assume it's aneurysmal when you have a patient that has subarachnoid hemorrhage, because aneurysmal bleeds are the most at high risk of bleeding again within the next 24 to 48 hours. So you have to assume it's aneurysmal and treat accordingly until you find an aneurysm or exclude an aneurysm. And again, the principles here are ABCDE, and here ABCDE is actually really important because you need, in subarachnoid hemorrhage, you need to maintain a good blood pressure, okay? You don't want it to be too high. Usually we're talking over 200 is very concerning, but actually over 180, systolic over 180 is also quite concerning, but over 200, you can think about probably lowering it. Reason being is that very high pressure can predispose an aneurysm to bleed again. But again, you don't want it to drop. So if a patient's normal blood pressure is 160 and they're responding because of the pain, say, and it's gone up to 180, you don't want to drop it aggressively, and you might not want to drop it at all. And the reason being is that subarachnoid patients are really at risk of developing vasospasm. The presence of blood in the subarachnoid space predisposes the vessels, the arteries on that same side of the brain to go undergoing vasospasm, which can be so severe that the patient strokes out. And that's a very serious consequence that you need to try and aggressively avoid. And that's why we give nimodipine. So nimodipine is one of the very few drugs in neurosurgery that a trial has been done, level 1 evidence, and it's quite strong evidence to highlight that it's a medication worth using. So nimodipine is a calcium channel blocker, and we give it 4 hourly orally, so that's quite frequently, for 21 days. And that has been shown to reduce the likelihood of vasospasm by calcium channel blockade causes vasodilation. So that has been shown to reduce the likelihood of vasospasm. Why we give laxatives, analgesia, antiemetics, darkened room, and bed rest is because we don't want the patient to in any way strain or move too much, because any of these things can increase the ICP, the intracranial pressure, and therefore, again, predispose potentially to a rebleed. So subarachnoid hemorrhage patients really vary in how unwell they are, but they can become really unwell. They can present really unwell, but critically they can present quite okay, GCS 15, just with a severe headache, and then they can deteriorate quite rapidly and become really unwell. And so if you're ever in a situation where you're having to see a patient who is a subarachnoid hemorrhage patient and they're deteriorating, and usually that will be if you're on a neurosurgical ward, but let's say it's a patient you've seen in A&E, they've got a subarachnoid hemorrhage, or a patient on the ward, you think they have a subarachnoid hemorrhage, and you're awaiting a transfer to a neurosurgical center. Okay, so it is still potential that you'll meet one of these patients before they've gone to a neurosurgical center. And the 5 causes of a GCS drop that you should be always having in mind in a subarachnoid hemorrhage patient are these: a rebleed from the aneurysm, very high risk in the first 24 to 48 hours. This is why we treat these patients aggressively. Hydrocephalus developing because of the blood in the CSF causing impairment in CSF flow or CSF reabsorption. Seizures, either because of the hematoma that can sometimes occur with subarachnoid, or just because of the irritant effect of blood itself on the brain. Hyponatremia. So subarachnoid hemorrhage patients very commonly get hyponatremia. So these patients often need daily bloods. And if you're starting to notice abnormalities, and sometimes we step it up to twice a day, and sometimes 4 times a day bloods to monitor their sodium. And then last but definitely not least is vasospasm, which, like I said, can be devastating and just cause a stroke by the sheer nature of how aggressively these arteries go into spasm. So one final case, and then we'll leave it at that, because I think there's one other key domain of neurosurgery that I haven't covered. So a 68-year-old who has a 7-month history of difficulty speaking. So it's a slow history, it's 7 months, and he's an elderly chap. His GCS is 15, and his pupils are equal and reactive, and there's no limb deficits. But you notice that he has papilledema, and he has an expressive dysphasia. So he understands everything you're saying, but he's really struggling to produce complete sentences. So this is his CT scan. So I'll give you a second to try to work out what's going on. Are they allowed to speak? or?
They don't have microphones on.
Okay, fine. All right, so this is a really good case, simply because I think this CT scan is really educational, because this CT scan on its own is very confusing. What you need is the CT scan with contrast, which is right here. So you can see that with contrast, something on the left, you would have probably, potentially a lot of people would have missed what the problem is, okay? And then on the right, you can see that there is a well demarcated, large lesion that is significantly contrast enhancing. So it's a very vascular lesion, okay? And I mean, I guess I don't have any microphones on because I'm going to ask people to guess what it is. But essentially, with a slow history like this, 7-month history, and it's contrast enhancing, then this is most likely going to be some sort of neoplasm, some sort of malignancy, okay, some sort of brain tumor. And obviously, I don't think at your stage you need to know the different types of brain tumors, but just recognizing a space occupying lesion on a CT scan is really important, because this is the kind of thing you definitely would refer to neurosurgery for their opinion. And he has an expressive dysphasia because it's on the left side and it's affecting near the frontal lobes. So it all kind of makes sense. For those who are interested, this sort of well circumscribed lesion that's so contrast enhancing and quite homogeneous is a meningioma. So very quick rundown on management of intracranial tumors if you're dealing with a patient who has an intracranial neoplasm. Again, ABCDE, I will always stress this. And in my interviews for neurosurgery, that was a lot of the marks are just for saying that and for going through that. If the tumor is causing associated hydrocephalus, then the patient will need CSF diversion or removal to relieve pressure. And that, depending on the anatomy of the tumor, can be with a lumbar puncture, or we can put in drains, so tubes that sit in there for a few days to help CSF leak out. And that can be a lumbar drain. So we can essentially, it's the same like a lumbar puncture, but you leave the needle in and you leave the tubing in, you suture it to the back. Or you do an EVD, which is essentially a hole through the top of the skull into the lateral ventricles. And again, you suture that in and let it drain for a few days to relieve pressure. If there's associated cerebral edema, this is again another one of the very few well-evidenced medications that we use in neurosurgery. If there's edema, so you can see around the tumor that there's areas of hypodensity, then you can use dexamethasone. And the patients often respond immediately, almost within a couple of hours, you will see a change in the patient because you reduce that swelling and you reduce that pressure intracranially, and their GCS improves, their headache improves. It's quite a nice one to see, actually. And then of course you'll give them high dose dexamethasone with PPI cover. So we usually use omeprazole. And if the patient has associated a high ICP because of the tumor or because of the bleed, sometimes bleeding happens into the tumor itself because of its abnormal nature, because it sometimes recruits abnormal blood vessels to it, then you manage it like any patient with high ICP with medical principles to try and bring down the pressure, with all the stuff that we said, using mannitol, using hypertonic saline, hyperventilation, and head elevation. And if the medical issues aren't working, then that's when you consider surgical principles, and that's when you're going to refer to neurosurgery for possible decompression or for treating something else that's causing the high ICP. So for example, if there's a hematoma, you can operate just to remove the hematoma, or if it's causing sort of, like I said, CSF obstruction, then you can use EVDs or lumbar drains. And if the patient is stable, then ultimately surgery, debulking or resection of the tumor directly is the mainstay of treatment. Unfortunately, as it stands for most intracranial tumors, there aren't really any good medical treatments. So as it stands, most intracranial neoplasms require surgery for resection or debulking at the very least. And you can see just as a final quick example, you can see for this example, it's a hypodense cystic lesion, and you can see around it here, a bit subtle, but there's edema surrounding it here. So this is a patient actually who's got a glioblastoma multiforme, and there's surrounding edema. So this kind of patient would respond to steroids. So this is just an example. When there is edema, then it's worth giving steroids. This case, for example, the meningioma, there's not a lot of steroids really. There's not a lot of edema really. So steroids, some people would give it, some people might not. Fine, so that's it. I think a quick run through. It's very difficult to summarize, but I hope that was useful. And any questions, and please leave feedback.
Thank you so much, Ahmad. That was great. Yeah, just reminder, guys, please leave feedback. It's really useful. We do have a few questions, if that's okay with you, Ahmad.
Yeah, sure.
First one is, why do patients with a subarachnoid hemorrhage get hyponatremia?
So I don't really think anyone knows, as far as I'm aware, and in everything I've read, I don't think anyone knows. But there's sort of two patterns that you get. You get a pattern of SIADH, syndrome of inappropriate antidiuretic hormone, where the patient is secreting a lot of ADH, and they essentially retain a lot of water, and they go hyponatremic but euvolemic. And then there's the other pattern called cerebral salt wasting, where essentially, again, it's thought to be because of sort of sympathetic overdrive that the patient loses a lot of salt and water. So in those patients, actually, they can become hypovolemic. But the exact pathogenesis as to why, I'm not really sure anyone is that sure.
Okay, thank you, great. Another question we've got is, why is an acute bleed hyperdense compared to a chronic one?
So with the acute bleed, you need to, it's really useful in surgery to try and go to theatre to visualize this stuff. Because once you've seen it once, I think it makes it easier. That's why I sort of put up the picture of the bleed. So fluid, and once it leaves the vascular space, it immediately clots. And when it's clot, it's more dense. So remember, the CT is all about density. A wider area is a denser area. So a clot is just more dense. And with the chronic bleeds, what's happened is that the immune system has reacted to the blood and has sort of digested the blood. And what happens when you digest the blood is it sort of turns into more of a liquid and expands in size. So then if it's more of a liquid, it's hypodense. So, I mean, the most useful thing is probably watch YouTube videos of evacuations of subdurals versus chronic subdurals, or get to theatre, you know, because they're very different. It's either a clot or liquid and watery.
We have quite a common question is, what helped you decide you wanted to do neurosurgery?
That's a very big question. I think so. It's a lot of things, really. Firstly, it's a fascination with the brain, and I think, look, there's going to be very cliche aspects to answering that question, which is love the brain, loved surgery, and when you're applying for national selection and they ask you that question, the moment you say that, I think, I mean, the guy who asked me, he looked like he was falling asleep, because they've heard this sort of same spiel. But it really is sort of cliche in that I quite like surgery. I quite like the immediacy of treating a patient, seeing a clear lesion. I really like anatomy. The brain is fascinating, and there's just a lot of unknowns about the brain. But in neurology, I think you all have to go out and sort of find your own experiences to decide. Because neurology, from my point of view, feels like a lot of requesting of interesting investigations and seeing patients with very interesting syndromes. But ultimately, you don't get the fun and the immediacy of surgery. And then in neurosurgery as well, we deal with very complicated patients who are complicated medically. So if you like ITU and acute medicine, then and you like just complicated medicine, then neurosurgery is full of that. And what else is there about neurosurgery? Just the fact that it's life and death and very, very intricate surgery means chances are I don't think I'm ever going to get bored. But right. Yeah, it's a big question.
Yeah. And the most common question that we've got asked tonight is any advice and tips on portfolio? What can they do now to try and prepare themselves better for that?
So I think I'm actually giving a talk about this in a few weeks. So maybe I'll send you, Kate, the link, and then you can send it out to your
yeah, we can do that
group.
for sure.
So essentially, the application process is you've got your sort of you first submit an online application form, and when you submit the online application form, you're assessed on certain criteria, and that is publications, how many of them have you got, audits, how many of them have you completed, and any that you haven't completed, you can still put in and it sort of counts in some ways. Involvement in any managerial roles, so even stuff like being involved as a president of a sports society or something counts. Involvement in teaching, and teaching where you've gotten feedback. So well done on Kate for organizing this. And what else did they test you on? So you get points actually for involvement in research generally. So even if you've done research projects and didn't get publications out of them, if you write it and you can evidence it in your portfolio, then that counts. What other categories were there? In the neurosurgery application form, there was actually a category asking involvement in activities that prove sort of physical abilities or physical dexterity. And honestly, I mean, I put things like having, done sports at university, and that counts. What other categories were there? And courses, that was another one. So it's quite useful, but often they only look at postgraduate courses. So they're slightly, because there's a lot of undergraduate courses you can do, which, very educational, but they're not sort of verified and not, you don't get sort of formal professional certificates from them. So sort of the big courses after you finish med school, like basic surgical skills, ATLS, advanced trauma and life support. There's a care of the critically ill surgical patient and care of the critically ill neurosurgical patient. These are two separate courses. So these are all, quite expensive and require quite some commitment to doing them. But essentially, yeah, you fill in the application form, and you then sit the MSRA exam, which is this very shoddy exam that essentially is the same exam they use for GPs, and your score from your form and your exam count towards getting an interview. And that's really the first hurdle, is just getting an interview. Then getting through the interviews, its own other hurdle that we can talk about another time. But what they're clearly looking for is someone who is sort of good at everything, but not necessarily exceptional at one thing. And I can, I say that so that people don't panic too much, because often I think in med school we get really focused on stuff to do with like publications. That's a very common anxiety people have. But actually, when I applied, I only had one publication. And then there were people who applied against me who didn't necessarily get interviews, who had PhDs and numerous publications from the PhDs. So they're looking for someone who, who has used their opportunities at medical school well, sort of develop a large set of skills, which includes research, but also includes involvement in hospital improvement, i.e. audits, and also shows that you're generally a okay human being. You can run a society or organize teaching like Kate is doing, or teach actually and not be hated too much when you're teaching. So there's lots of things that you need to be dabbling into, really.
Fantastic. Thank you so much, Ahmad. It's been a very useful talk. Really appreciate you coming to talk to us today. Guys, before you go, please, just one more reminder to do the feedback form. It literally only takes 2 minutes. It's really, really quick. We'd appreciate that. Yeah. Thank you very much, Ahmad. And we'll see you guys next week for handling the on-calls as an F1.